The electrocardiogram, also known as an ECG or EKG, is one of the most commonly used tools in clinical practice. In this video, I'll provide a systematic approach that'll help you read ECGs more confidently. A normal 12-lead ECG is obtained using 4 limb electrodes, 6 chest electrodes. Together, these electrodes create 12 different leads, each providing a slightly different view of the heart. When the electrical activity of the heart moves towards an electrode, the deflection is positive. When it moves away from the electrode, the deflection is negative. If you'd like to review how to place the 12-lead ECG, check the link in the description for a detailed video. Now, let's quickly recall the anatomical views. Leads 1, AVL, V5, and V6 look at the lateral part of the heart. Leads 2, 3, and AVF look at the inferior part. Leads V1 to V4 provide a septal and anterior view. The first step in interpretation is to ensure correct calibration of the machine. The standard speed is 25 millimeters per second. The standard amplitude is 10 millimeters per millivolt. If these settings are incorrect, the ECG can look completely different, so you should always confirm them before you start interpreting. Next, we look at the axis. The axis represents the overall direction of electrical activity in the heart, and normally it lies between negative 30 degrees and plus 90 degrees. It may be normal, deviated to the left, deviated to the right, or extremely deviated. A quick way to determine this is the quadrant method by looking at lead 1 and AVF. If both are positive, the axis is normal. If lead 1 is negative and AVF is positive, this is right axis deviation. If both are negative, this is extreme axis deviation. If lead 1 is positive and AVF is negative, the axis may be normal or left axis deviation. To confirm, check lead 2. If it is negative, then it is indeed left axis deviation. Next, we assess the heart rate. On standard ECG paper, each small square represents 0.04 seconds, and each large square, made of 5 small ones, represents 0.20 seconds. 5 large squares, 1 second. 300 divided by the number of large squares between QRS complexes gives the approximate heart rate, useful for regular rhythms. For example, 1 large square, 300 beats per minute. 2 large squares, 150 beats per minute. 3 large squares, 100 beats per minute. 4 large squares, 75 beats per minute. 5 large squares, 60 beats per minute. If the rhythm is irregular, count the number of QRS complexes in 10 seconds and multiply by 6 to get the rate per minute. The normal rate is 60 to 100 beats per minute. Below 60 equals bradycardia, above 100 equals tachycardia.
That brings us to rhythm, which answers the question, do the beats fall at regular intervals? We assess this by looking at the RR interval. If the distance between QRS complexes is consistent, the rhythm is regular. If the distance varies, the rhythm is irregular. Irregular rhythms can be irregularly irregular, such as atrial fibrillation, regularly irregular, which may be seen in some second-degree heart blocks, and that gives us a systematic start. Calibration, axis, rate, rhythm. From here, we can move forward into intervals, waveforms, and more advanced interpretation.